Welcome everyone to this webinar sponsored by the Department of Cardiac Surgery at the University of Michigan and the section of Health Services Research and Quality. My name is Don Ilikoski and I am the head of this section. And our section really inspires our activity through our why. And our why is to advance health and healthcare. And with this in mind, one of the things that we have been focusing on is trying to understand the clinical setting a little bit more. And we're delighted to have with us Dr. Gorav Ailawadi. Dr. Ailawadi is the chair of the Department of Cardiac Surgery and previously served as the chief of cardiac surgery at the University of Michigan, was the co-director of the Cardiac Valve Center and director of the Medical Device Innovation Center. He's well known domestically as well as internationally, and we're delighted to have him give a clinical lecture in this series. He has the following disclosures. And today he'll be talking on the title of Minimally Invasive and Transcatheter Mitral and Tricuspid Therapies. We have the following guidelines to help make sure that this webinar goes smoothly. We're not expecting your video to be shared, and we'll be recording this session to post on the YouTube channel. And if you want, you can also receive contact hours at the end, and I will have 2 slides at the end after Dr. Ailawadi's lecture. So without further ado, thank you, Dr. Ailawadi, for joining us today.
Great. Thank you, Donnie and Holly, for inviting me. I'm going to go and start by sharing my screen. I'll talk about this topic that it's been near and dear to me for the last several years, as I've been able to be involved in a lot of the new technologies that device companies have helped us bring into patients. And as a result, I do have some conflicts as listed here that Donnie had outlined. So I'll talk a bit about mitral valve options, then we'll talk about the tricuspid valve, and give you certainly my general approach to these patients, as well as why I think it's important that we work in our team. And I'm sure that this audience, as much as anybody, understands how important that is. So traditional heart surgery begins with a saw. And this is what, in general, about when you think about how TAVR all started and the revolution with less invasive and percutaneous therapies, it really began with patients and cardiologists driving, saying, you know, heart surgery, it's a big saw. You're going to have your chest sawed open. Your chest will be open for hours. Days later, you'll be feeling a little rough, but in the ICU, able to give a thumbs up. And then at the end of the day, when you heal up, you have a nice scar on your chest, but a beautiful valve. And what they have been able to sell, and I want to say they, but it's really all of us working as a team, the transcatheter procedures, as you know, are a needle stick. And then depending on the type of procedure, this is happens to be a MitraClip, probably 30 to 60 minutes. And I think the record time that I've seen in our team with performing a MitraClip has been about 18 minutes from start to finish. And then a day later, the patient is out of the hospital and active again. So it is hard to argue with this. Patients are consumers, and we have to respond and offer that and push the envelope and find new technologies that benefit them. So I'll talk about the mitral valve. And one of the unique things about being a surgeon in this space is that it has adapted to not just open surgery, but the less invasive and percutaneous approaches, is that as a individual provider, we're able to hopefully be unbiased and non-committal to a particular approach and be able to offer all of the potential approaches. And so we have all the tools in the toolbox, so to speak, as opposed to I only do one thing and that's open surgery, or maybe some cardiologist out in the community only does one thing to the mitral valve, and that's MitraClip. Fortunately, as a surgeon in this space, and having the option to offer any of those, and hopefully in an unbiased approach. And here we see the spectrum of options that are available for MitraClip, being the most easiest way, the least invasive, if you will, and all the way to transcatheter mitral replacement, which right now is an apical incision then robotic and port access or minimally invasive, which is what I tend to do a lot of, and then open surgery, increasing the invasiveness. But then you can also argue that you lose some efficacy. And so the other way we think about the mitral valve, as you know, is there are different reasons why mitral valves leak. And primarily we're going to talk about regurgitation, but stenosis also has its own can of worms, if you will. But we'll talk a bit about primary mitral regurgitation, which is where the mitral valve itself is abnormal. When you think about a flail or a prolapse, also called degenerative mitral valve disease, where secondary mitral regurgitation is a result of something wrong, something else wrong, and the valve itself is fine. It looks fine. The anatomy is fine, but it's secondary typically to the left ventricle being dilated, the ejection fraction dropping, and essentially pulling the mitral valve open. So when it comes to primary mitral regurgitation, we'll start with a case and maybe start there. And as we get to questions, we can talk about how the approach has evolved. But this was a patient referred many years ago, before MitraClip really had quite the same, our understanding was quite limited, but a 91-year-old who was fairly active and did not appear anywhere near his stated age. And the only symptom he had was he would get short of breath with his wife when he was dancing with him after about 45 minutes. And it turned out he had an STS risk of mortality of about 6%. And what you can see here, he had a large flail posterior leaflet. And that's what we see here. I don't know if you could see my pointer. And the algorithm has changed. And at that time, people that were in that classification, we didn't really have the ability to offer MitraClip. That's evolved now in 2021. And so we think about low and medium risk patients. We have mostly surgical options. There is a trial that we have just started here in medium risk patients or intermediate risk patients with an STS risk of 2 to 6%, that they can be in a clinical trial where there's a 50-50 chance they get MitraClip and a 50-50 chance they get surgery of any type of approach, mini, open, robotic. And that is a trial that Michigan is now a part of, and we are hopefully going to start enrolling soon in that trial. However, the high risk, prohibitive risk, inoperable, typically we tend to push to the transcatheter procedures because they tend to be, I think, less invasive, albeit potentially with more limited types of anatomy and patient classifications that we can offer them to. So in the end, it really is a heart team shared decision-making approach with the patient, and the patient ultimately helps decide what they feel they're willing to undergo. So let's think about mitral valve surgery itself, and the approach I mentioned is minimally invasive approaches is what I tend to focus on and study. And this was a presentation years ago looking at what are the outcomes with minimally invasive surgery compared to a conventional sternotomy, which is, we look in the United States, probably about 75 to 80% of all mitral valve surgeries done through a conventional sternotomy. You see the variation here at our own institution. And what we essentially did is we compared minimally invasive mitral valve surgery to conventional surgery. And this was an experience where we matched patients. And what you can see is we found a couple things. One is the bypass times are longer, cross-clamp times are longer, because it does take longer to do the less invasive approaches. However, there's really good outcomes in terms of you can really handle pretty much anything, the tricuspid valve, Mays procedure. There is really very low conversion rates to a sternotomy. And if we look at specifically those with degenerative mitral valve regurgitation who should have a high repair rate, we essentially had equal repair rates with either approach. And my general opinion is if you're going to do another alternative approach, you should have the same results in terms of repairability and overall outcomes. So, and then operative mortality and major risks were really no different. Importantly, the risks of transfusion were far, far less with minimally invasive approaches. And as you can imagine, that makes sense. You don't have a chest open, that's sternum bleeding, and it is fairly uncommon that these patients need a blood transfusion. I'll just try to show a very brief video, and we can kind of skip through it. This is what the incision looks like, and we do use, so we go in the right chest, make probably about a 2 to 3 inch incision, and then we do cannulate the patient. There's some coding things that go into that, how we cannulate. And here now we're actually opening the pericardium, and we're careful to avoid the phrenic nerve sits right along the pericardium. We're making sure we don't injure that. But what you're going to find out here soon is that the exposure for this is actually quite good. And so here we're just opening up the Watterson's groove. It's part of the technical way of how we get into the mitral valve. A lot of patients ask, how do you get to the mitral valve from the right chest? It turns out that the mitral valve sits in the middle of the chest, or actually a little bit on the left side of the chest, and it directly faces the right chest. So we're looking directly at the valve, as opposed to through a sternotomy, we have to rotate the whole heart so we can see the valve. So here we're putting a cardioplegia needle, and that's the solution we give to the heart to stop the heart. And then the next thing we'll do is we'll go ahead and clamp the aorta. And this is a special clamp that exists to allow this to be put in through a minimally invasive approach. And again, what you're going to see here is a very direct exposure of the mitral valve. And this is the mitral valve anterior and posterior leaflet. Now we're putting annular sutures around. We do use a camera for all cases, and it helps both for our visualization with lighting, as well as for others in the room, and very helpful for training and the OR team to know what we're doing. So in this particular case, this is an annuloplasty ring being placed. The valve itself was relatively normal, but a little dilated. Here we're now filling the ventricle to start deciding how do we want to repair after we present the valve with sutures around the annulus. And you can see just with an annuloplasty, there's a good coaptation. Then we go ahead and size the ring and decide what ring. And we have a couple of special devices, a core knot, which you may have heard about. It's a special clip knot. And then we can do our final testing. So the reason I like this approach is it's very anatomic for the valve. It does take longer for the surgeon, there's no question, but for the benefit of the patient, there is, I think, more rapid recovery. They can return to work faster. They can return to driving faster. And we can pretty much do just about any mitral valve or tricuspid valve procedure through this approach. And that's my general approach. And I think how many out there that are sort of mitral valve zealots believe that this is potentially a beneficial approach. We've actually done a separate study that I didn't necessarily include here in this talk, where we were compared through the Virginia State Quality Database that there is actually superior outcomes with minimally invasive versus sternotomy. And I think it's a function of the individual surgeons who have large volumes. They tend to gravitate, many of them, not all, tend to gravitate through minimally invasive approaches. I want to mention that we can do all the same techniques that we do with surgery. This is somebody with a Flail leaflet on the left side. You can see what the valve looked like before, and then afterwards we're using artificial cords. So we're replacing essentially the torn cords with Cortex suture that's fine, very strong suture. We put a ring around it, and then we ultimately do testing to make sure, and there's really excellent results with that approach as well. And this is our particular patient that was the 91-year-old, again, that did not have a option for MitraClip at that time. You can argue probably in today's world that would be different. And you can see had no residual mitral valve leakage. This is what his incision looked like. I don't know if he's still alive now. This was probably 8 years ago. I would be surprised, but I know he was alive still at 4 or 5 years, asymptomatic. So I did mention there is a trial for intermediate risk patients to get MitraClip versus surgery, and that's an STS risk of 2 to 6%. Now I do want to mention a little bit about another group of patients that we see, and those are those with mitral annular calcification. So for some reason, some patients develop calcium buildup around their valve. Not all, but some do, and it can be quite severe. And in and of itself is not dangerous to the patient that they have calcium, but it can make surgery nearly impossible or extremely high risk, because the calcium quality can be as rigid as a lead pipe, so we can't put sutures through it, or it could be as fragile as an eggshell, where we put a needle through it and it breaks into multiple fragments, thereby increasing the risk of stroke. So there's some alternative ways that we've developed to try to minimize the risk. So this was a lady that presented to me a few years ago, 81-year-old with very advanced disease, was class 4 heart failure, was in a wheelchair, essentially, had such bad symptoms she could not get up and walk around, even within her house, had been hospitalized twice in the last 2 months for heart failure. She had a complicated surgical history with bypass surgery and aortic valve replacement, but then the kicker was she developed a deep sternal wound infection. So it doesn't just happen in Michigan, and ended up needing a sternectomy and had no sternum, essentially had a pec flap. Well, when she presented to us years later, she had severe mitral stenosis and had a mean gradient of 14 across her mitral valve. And what that means is the gradient between the left atrium and the left ventricle, and anything over about 10, 8 to 10, is pretty severe mitral stenosis. And this particular patient had very high gradients. And you can see she had pulmonary hypertension, and her risk of surgery was quite high at 10%. And that doesn't even account the mitral annular calcification. So this is what her CT scan looks like. And what you could see, this is her mitral valve. You should not be able to see the outline of her mitral valve on a CT scan like this. Why this lights up, this is not contrast. This is actually calcium around her mitral valve. So in order to fix this, it needs a mitral valve replacement. We essentially have to clean out the calcium to allow sutures. And that can be challenging for many reasons. And as I mentioned, and you can actually, if the calcium burrows into the ventricle and tears off the ventricle, it can cause a disruption of the atrium and ventricle called an AV groove disruption. And that essentially is a death sentence, if you will. So we talked about other ways to do this. And fortunately, we have had a trial at Virginia that we actually just opened up here as of this week, called the Mitral trial. And what it is, it's placing a sapien valve in the mitral position. The sapien valve, you may or may not know, is the TAVR valve that we use that's balloon expandable. And I'll show you some pictures of that. So this patient underwent a minimally invasive approach to this. And this is her valve. There is a lot of calcium around this valve. May or may not be able to appreciate that. We can actually remove some of the valve, take out some of the muscle that will allow space for the valve to be placed without affecting blood flow in the ventricle. We actually can put felt in the landing zone, and then we go ahead and deploy. This looks like a normal surgical valve. This is actually a sapien valve, a transcatheter valve that we're putting under direct visualization in the mitral space and using this felt as sort of a landing pillow, if you will, to prevent leaks around the valve. And these patients, when done well, can have really outstanding results. And what you can see here is that the valve's functioning beautifully. What we worried about when we first started this is we cause issues with blood flow out of the heart and cause an outflow tract obstruction, and patients essentially will die from that. The other is that they can develop leaks around the valve because you're not really putting a lot of sutures in. And we've found that with this technique, we can really decrease those risks. So another way to handle this is a new procedure that is in clinical trial in the United States. And I'm also pleased that Michigan is really taken this by the horns, and we've, as soon as we've gotten approval, we've now rapidly enrolled 3 patients in this trial. But the leaders are sort of in the 20 patient range, and we are eager to reach that status, and I'm confident. Matt Romano is our PI for that trial here. So this was another approach. It's called the Tendyne valve. And this is a patient that a friend of mine, Paul Siraj at the Minneapolis Heart Institute, first thought of using a transcatheter mitral valve replacement for severe MAC. This is a very sick lady with bad heart failure. And what I want to show here is she has, there we go. She has, again, on this CT scan, what you'll find is really horrific calcium around her mitral valve. To operate on this with a conventional approach would be extremely high risk, and no STS calculator accounts for this. And Paul had the idea of using Tendyne. He had been working with a company, and this is a transapical mitral valve replacement. So the benefit here is no sutures, no heart-lung machine, and you don't stop the heart. And putting this into the mitral position, and I'll show you a little video that shows what this looks like. It is a transapical incision. So we do this in the hybrid lab here. So through an incision on the left side, we go directly into the apex of the heart. It is a large sheath. It's 35 French, so it's probably about a centimeter to a centimeter and a half in size. That's the size hole that we're going to make from the left ventricle. So it is not perfect yet. And here now we're going ahead and putting a sheath in. Within that sheath, we have the valve that's going to be advanced. And this is the Tendyne valve, and I'll just show you what that looks like. We open the valve, put it in position. The one thing that's unique about this particular valve is it is repositionable. If we don't like what it looks like, we can turn it, we can remove it. And if ultimately we don't like how it looks, we can actually take it out of the patient entirely. So this is a not a mechanical valve, it's a biological valve. However, we do put people on blood thinners after this for about 6 months. And why it's called Tendyne, it has this unique apical tether that allows for a couple things. The valve seats better, and also you prevent bleeding from the LV apex, which is a big concern with this procedure. So this is, I'm going to show how the results went. This is echo showing how the valve is opening up. We don't need to pace the heart. You can see the valve is now fully opened. This is kind of like the view from the top down of the valve, or what we as surgeons see. And then you could see the valves functioning beautifully here with no leakage, and it's wide open. And this is a CAT scan kind of showing what that valve looks like sitting in place. It's really quite remarkable. And we expect this valve has just received FDA breakthrough designation this week. So what that means is, as the trial is ongoing and is completed, we anticipate we will get FDA approval fairly rapidly for this patient population. And this is an absolute huge need. So I'll now shift gears and talk a little bit about secondary mitral regurgitation. As I mentioned, that's a result of the ventricle being depressed, and there's no actual problem with the mitral valve itself, yet patients can have severely leaking mitral valves. And these tend to be a very different patient profile than the earlier patients. This was a 78-year-old male with oftentimes with coronary artery disease, and this particular patient had a CABG, had PCI, had an ejection fraction of 20%. And he was in the hospital with class 4 heart failure with severe functional tricuspid regurgitation. His coronary disease had no reconstructible disease that needed to be addressed. His STS risk for surgery was 12%, so clearly a high-risk patient. And this is an echo showing his mitral valve, his left ventricle, and there's a lot of leak into his left atrium. And it's really causing his symptoms and a big part of his symptoms. So the algorithm that really has developed as a result of the COAP trial, there was a large trial where we performed MitraClip in these patients compared to medical therapy that came out in 2020, essentially showed that there was a dramatic improvement in life expectancy, in symptoms, and hospitalization when we offer MitraClip. So in this patient population, different from degenerative mitral regurgitation, low and medium risk patients, medical therapy with diuretics and heart failure medications and MitraClip really become more first line. And mitral valve surgery really has fallen away. In reality, it was less than 5% of the patients that we operated on, even before that, had purely functional mitral regurgitation within the United States. And then the really high-risk patients, we now have lots of new devices because some of these patients, we don't think just putting some small clips in will really have that much benefit to fixing the mitral valve, and that's where the transcatheter replacements play a part. And I'm going to just show a couple slides why this is the case. This is, again, the COAP trial, and this was a trial that ultimately led to approval for MitraClip and essentially showed both lower heart failure hospitalization as well as mortality at 24 months. And what this slide shows is the outcomes from that trial. And what you'll see in green is the heart failure hospitalizations, and the mortality looked exactly the same, mimic this, that there's much lower mortality and heart failure hospitalizations in patients in green who got a MitraClip rather than just medical therapy alone. And this is that particular patient. Now we're offering MitraClip to those patients. This patient had a MitraClip procedure, and you can see the end result is very little residual mitral regurgitation. He was able to improve his symptoms, improved from class 4 to class 2, had trace residual mitral regurgitation. You can see we didn't do anything to his ventricle. It still looks quite poor, but he is symptomatically much better. So MitraClip is really the first tool in the toolbox. There are many other tools ranging from less invasive surgery to these new devices. Some of the other devices that we've been fortunate to be a part of, and we're part of here, is another device that looks a bit similar to MitraClip, where we're clipping the valve together, is the Pascal device. It's a different company. They actually put a little spacer in there, so they call it a bit different from truly a MitraClip, but it's essentially the same approach. And we were fortunate to have been involved very early on. This is a patient with functional regurgitation who ended up having a nice result with 2 devices. So all these devices are in investigation in the mitral space. We have lots to offer, and I think one thing that's unique here is through a heart team approach, we can decide what's best for every individual patient, whether it's open heart surgery, minimally invasive surgery, or any of the host of new transcatheter devices that we have here. If we think about where that stands in the state, for example, there are many sites that have MitraClip programs because it is commercially available. There are very few other sites that have the newer devices like Pascal or the transcatheter mitral valve replacement, where those patients don't have other options and they need to come to a site that has access to these. So I'll shift gears for a moment and now talk about the tricuspid valve. And what's interesting is we've always thought about the tricuspid valve as I don't know if any of you know, but the nickname for the tricuspid valve is the forgotten valve. And people tend to forget it because they think, well, you fix the mitral valve and the tricuspid valve will get better. We're now learning a lot more and more, and there's more data that's coming out that may not actually be the case. And there are many patients that have very advanced tricuspid valve disease that end up getting referred to us because in general, the only tool that we've had for many years has been tricuspid valve surgery. And the way I describe the tricuspid valve to patients, it is the simplest valve for us to access. It's actually the simplest valve for us to operate on because it's so close to the chest. It's so easy to get to. However, when you operate on the tricuspid valve, and if we look at the database in the US and we look at the database in Michigan, the mortality for isolated tricuspid valve surgery is quite high. It's about 10%. The reason for that is when you have a severely leaking tricuspid valve, it is a marker for right ventricular dysfunction. What does that really mean? Well, it means that you die kind of a morbid death. You have multi-system organ failure. Your liver starts failing. As the right ventricle dilates and weakens, and the tricuspid valve is leaking, you get damaged backup of blood to the liver and the kidneys, and both of those organs tend to do very poorly. And so when we operate upon the tricuspid valve, sometimes we unmask this underlying liver disease and kidney disease. So there are many patients that present to us, and it was always thought that the population for tricuspid valve disease is much smaller than the mitral valve. Turns out, at least what we're seeing now, is that's not the case. We have so many patients that are referred to us with advanced tricuspid valve disease. This is an example of a very common patient that we see where we're trying to decide what's the best approach. This was a 77-year-old male who was referred, this is probably in 2018 or 2019 that we saw him, a retired airline executive. He had class 3 heart failure, had already had heart surgery with an aortic valve replacement and an ablation. He had a pacemaker had been put in for many, many years due to his atrial fibrillation. He had some other comorbidities. He had solid atrial fibrillation, had COPD, and you can see his lung function was marginally bad, not horrific. He also had some other comorbidities. He was a recovering alcoholic, and when we think about tricuspid valve disease and the damage to the liver, and as well as alcoholism, we were very concerned about his liver. And we use something called the MELD score, which is a way to calculate how much liver disease somebody has. When somebody has a MELD over about 15, they actually might become candidates for a liver transplant. So this particular patient had a MELD of 13. A normal MELD should be low, less than 3. So he had some kidney disease. His bilirubin was abnormal, which is a sign of liver disease. He was on Coumadin, so we had a difficulty using that as a marker for what his liver function was like. You can see here on his echo, he actually had a pacemaker lead, which is not uncommon in patients with tricuspid valve disease. We're learning more and more that patients with pacemaker have some risks of developing late tricuspid valve regurgitation, as this patient did. And this patient had a very complex leak. If you look carefully, there was 2 jets on his tricuspid valve, and his lead was somewhat involved. So the options we could offer at that time, and I think that's even advanced now further in 2021 compared to 2019, ranged from surgery to transcatheter repairs. And we had at that time in our hands access to putting a ring around the tricuspid valve through a groin through a percutaneous procedure. We felt ultimately that might not have been an option, as well as an edge to edge like a MitraClip put in the tricuspid position. So how do we try to figure this out? There is not a good STS risk calculator for this. Years ago, when I was in Virginia, we worked with Donnie, Rich Prager, Steve Bowling to work with our collective statewide databases to try to develop a risk model for isolated tricuspid valve surgery. This, to my knowledge, is the only model that exists right now. It still needs to be validated. But using our combined databases with, I think, over 2,000 patients, we developed a risk calculator that we now try to use here when we're evaluating patients with a relatively good AUC, 0.74. And if I recall, my understanding is the STS database has an AUC of somewhere between 0.8 to 0.84. So this was a relatively good model based on that, but again, still needs to be validated. The patient I just presented had a risk score of 7. What that resulted in his operative mortality was 12%, and he had a major morbidity of 42%. Ultimately, we shared this with him, actually shared this paper with him. He was a very sharp individual, and we discussed some of the devices that we had in trials, annuloplasty and clips, and ultimately he did not want something that was uncertain. He really wanted to get things fixed once and for all. So we admitted him prior to surgery, optimized him medically. We diuresed him. He had 9 liters of fluid removed, and ultimately his kidney function and bilirubin got better. And that, again, we do that oftentimes before any type of high-risk surgery to try to optimize the risk. So in this particular case, we did offer a minimally invasive approach, and this is his case. You can see he had this pacemaker in place, and we can keep his heart beating. We put this ring on, and we can see that the lead itself is probably contributing along with the valve being dilated. And we can actually tack the lead in a place to minimize the risk. And so we're actually suturing the lead to the ring itself, so it kind of is in a lower profile out of the way. And then what you can see we're doing is we're testing the valve and seeing that there is no real leakage. And the yellow cord that you see, that's actually the pulmonary artery catheter that we're using to manage the patient after surgery that will get removed before discharge. So let's see if this is working. And he essentially had no residual leak of his mitral valve, of his tricuspid valve whatsoever. Let's see. So I'll share another case where there's sometimes, decisions that we need to make between these options. And this was an 82-year-old lady who was quite a bit more frail than the first patient, had class 3 heart failure. And patients, when they typically have tricuspid valve disease, they don't have the typical symptoms of heart failure like being short of breath. What they feel like is they feel like they run out of gas. They essentially have no cardiac output. And as we're learning, we have to listen carefully to these patients because they feel fatigued and very diminished. And that's something that it's easy for a physician to write off saying, well, you're just getting older, and not necessarily that you have something going on with your heart, particularly with your tricuspid valve. So the patient I just presented had a different risk score of about 15%. And this patient we really felt like was not a good candidate for surgery. And we do have a number of options that are out there, most of which we have here at the University of Michigan. These edge-to-edge devices, so tricuspid MitraClip, Pascal will clip the valve together, and we're enrolling in both of those trials. We are just set to undergo a percutaneous tricuspid valve replacement with this particular device called the Evoke valve. We also have another valve called the Intrepid valve, which I'll show you in a moment. And then there was also a Cardioband device, which is a ring that goes around the tricuspid valve that currently is on hold, and Michigan is not a part of it right now. And the company is trying to redesign it to make it easier, because only about 3 people in the country could learn how to do this. But essentially, it's putting little anchors and a band around the tricuspid valve and then cinching it up. And this is our particular patient who had that done. And you can see we put the anchors here on the left side, and on the right side, we've actually cinched it up. If you look at the diameter of the tricuspid valve, this is a ring that's going around the tricuspid valve. When we cinch it up on the right, you can see how much it's smaller on the right side after we shorten the valve. And I'll show you an echo. And the before picture is on the left. You can see there's a lot of leakage of the tricuspid valve. And on the right side, the after, and it's really come down quite a bit to mild leakage. So there's another device called the Pascal, which is the clip I showed, the 2nd generation clip by a competitor, where they're putting a little spacer in. We're part of this trial here as well at Michigan. And this is another percutaneous device. And I thought this was a nice animation for you to see. This is the tricuspid valve. We don't have to puncture a hole in the heart because the tricuspid valve is on the vein side. And similar to a tricuspid clip, we can drive this device in place, and we're watching this under echo. The heart's beating. There's no incisions. It's just a needle stick in the groin. But we can go ahead and position the tricuspid valve in place, and the tricuspid clip, or in this case, the Pascal device, in place. It is iterative, so if we don't like it, we can move it and open it till we get to a point. One thing that's unique about these devices, and nowadays you can grab each part of the valve separately. For many, many years, you had to capture it all at once, and it was very challenging to do, and resulted in suboptimal outcomes. And this is a new technologies that we have here that we can offer in a much less invasive approach, as these patients are really at quite high risk for surgery. And so this was actually one of the first devices that I was involved in. And what we show on the left, we're actually driving the device in place. And then you can see the before and after. We had an excellent result with really minimal residual leakage with 2 devices. As I mentioned, MitraClip also has their version of this clinical trial that we're a part of. And you could see about 60% of patients feel dramatically better when we're able to perform these procedures successfully. And I mentioned there's now 2 devices where we can outright replace the valve, because not every patient we can repair the valve itself. And why do we think about this? The repair technologies oftentimes don't need a blood thinner, but all the replacement technologies right now need a blood thinner for a minimum of 6 months, potentially longer. And you can imagine some of these frail patients that are in their 80s, they're not good candidates for being on a blood thinner. And so that's why we have all these options that we're trying to sort out what's the best. And I'm not sure we all know the results yet of what's best for every patient. So this is, again, a valve replacement through the groin. And you can see kind of what it might look like. And this is a device. There's been probably about 150 done in the United States and in the world. We are about ready to open up enrollment. It's in a clinical trial, and we're probably a few weeks away from being able to offer this here at Michigan. And you can see the valve, the way it works. It's got 9 sort of arms that grab the valve itself, grab the native valve itself, and then we can open up the valve in position, capturing the native valve and then opening up the new valve. And there are multiple different sizes. And you can see this is all kind of done under echo. And this is our first case that I was involved with a few years ago. And you can see there's really wide open leakage, and all this color is leaking tricuspid valve. And this patient was absolutely miserable. And here we are opening those little arms and making sure with echo that each of those arms are in position, and then ultimately deploying the valve. And here we see there's no residual leakage, no color of this valve, and an excellent result. And these patients, they go home the next day, compared to the tricuspid valve surgery patients, which often are here for quite a long time. So I did mention that Michigan is involved in another device as well, the Intrepid valve, which is made by Medtronic, another company. And we were really at the leaders of this. We were the first in the United States to put in this valve in early feasibility study. There'd only been 4 cases prior to that in a compassionate use. So really at the forefront. We actually have done our 4th patient now. There's only been 7 or 8 done in the country in this trial. And so we're really leading the way with this technology. So I'll just conclude with these devices and structural heart therapies are really moving so quickly that every few months there's more updates. At every meeting we're hearing more updates on how the outcomes are going. They're iterative, so the companies are then going back, especially if they're in early feasibility trials, to redesign devices. And I suspect that we'll see some redesigns that become less invasive. These are still really large. Some of these are very large devices that are going into the heart. We want to see the profile get smaller. One thing that's unique, and you'll see this is really a good combination of surgery and cardiology working together, similar to what we see in heart failure with LVADs and transplant, structural heart disease, which really are mitral, tricuspid, and aortic valve disease. We've really become close confidants and best friends. And really this team approach of deciding what's best for every patient, and we discuss every patient probably ad nauseum, but hopefully to their benefit as to which approach is best among the entire continuum. And I'm really pleased that Michigan has become a leader over the last several years in these novel therapies, and we will continue to push the envelope and lead the way with the team that's here. So with that, I'll end. I want to thank you, and I'm honored to be here at Michigan with such an outstanding team. And I want to emphasize how important the team that I'm presenting to is in really watching our outcomes and making sure and helping us to define how do we get better. And that's really the question that I always ask myself and ask our team: how do we continue to evolve and get better? Thank you.